And then, well, thank you for asking me to do it again. I've updated it a bit. So for people who haven't seen it or saw it, hopefully it's somewhat of a refresher. Anyway, what I wanted to do is talk about urologic malpractice. I have some experience in it from consulting with some legal cases, and we put together this talk. So this is GU malpractice, or let's see, why is this not working? Or how not to get sued, as I entitled it. So I have a couple of disclosures. One is I'm not an attorney, so I don't have like an MD and a JD like some much more motivated people do. And none of the cases I'm going to present are actual patients. I've had to change things around sort of to protect the innocent. But I have had probably 10 years worth of experience of looking at malpractice cases. So as an overview, I want to talk about a bit of the scope of the problem and do a brief literature review of what's out there. The nice thing about urology and malpractice is you can become pretty much of an expert in about 15 minutes, since there's very few articles on this. We're going to talk about specific areas of litigation where I've sort of grouped it into failure to communicate results, failure to recognize problems, obvious failure to perform the surgery appropriately, topic I sort of called getting broadsided by colleagues, and then we're going to talk about need for appropriate documentation and how the EMR can be dangerous and can really cause a problem for you if you're not super focused on it. So why did doctors get sued? Well, so a couple sort of big baskets. Obviously, not knowing one's limitations. So if you are doing things you shouldn't be doing things you aren't super well trained to do, or things you aren't comfortable doing. Being lazy, I mean, that obviously makes sense, but if you're overworked and sloppy, most doctors don't get sued because they've really done something nefarious. It's, you know, and things where people miss diagnoses, it's usually just because people are overworked and they're dealing with, you know, a million things that day, and this is the 1,000,001th thing that's come across your desk that you miss. Obviously, not being truthful and honest is problematic. Not being insistent on good processes. Just because something has historically been done one way doesn't mean you have to do it that way if you don't feel it makes sense. And that's it. So there's 4 elements of negligence. So this is sort of a legal framework for what malpractice is. So there has to be an existence of duty by the doctor to the patient. So this is obvious, right? If somebody's your patient, you have a duty to manage them appropriately. There is to be a breach of the duty, meaning that something didn't go right. And really what this means is there's been a deviation from the standard of care. And we're going to talk about standard of care because it's a sort of complicated phrase. There is to be a resultant harm to the patient. You could do something totally stupid, but if there's no harm, there's not obvious malpractice. And then obviously there's got to be a connection between your deviation and the plaintiff's injury. And those are sort of the 4 elements that a lawyer will look at to determine if there has been malpractice. And so what is standard of care? This is a complicated term, really. It's a legal term. It's not a medical term. I've never ever been to a lecture, and I've never made rounds with my residents and I told them, this is what we're going to do is the standard of care. It's really a legal term. And there's been a lot of iterations of how people define standard of care. It could be what is commonly done. It could be what is reasonably done. What would a reasonable doctor do? Other places have looked at what would a minimally competent physician do. This is obviously a much lower bar than what an average doctor would do. But at the end of the day, a judge and a jury determines the standard of care, right? The legal system we have here in America, we don't have like a board that determines if a urologist did something incorrect or correctly. It would be very nice if, you know, anytime a patient feels that they've been harmed or wronged, they send their, you know, medical chart to, let's say, the AUA, and a board of 7 expert urologists looks at it and says, no, this unfortunate problem is, you know, a normal postoperative complication. Sorry, there's no malpractice. Or, wow, yeah, this doctor, you know, actually did something sort of horrendous and we're sorry. And, we think you should get a check for $100,000. But that's not the system we have. Obviously, we go to civil trial, and that's what malpractice is. And so who helps the jury define what's the standard of care? It's really expert witnesses, which are urologists, right? So to be an expert witness in urology, the AUA has a code of what expert witnesses should be. You have to be a practicing urologist. You have to be ABU certified. You should be in practice greater than 5 years. Obviously, you should only testify in areas that one is familiar with. You know, if you're never do pediatric urology, you shouldn't really testify in, you know, a pediatric urology case. And you must review all the records prior to providing opinion. This is just on the AUA website. They go a little further, though. You should be willing to serve for either plaintiff or defendant. And they comment that the most objective testimony could be used by either side. This is important because what they're trying to do is really cone down on, you know, people who are just providing plaintiff's experts or people who just act as a plaintiff's expert or vice versa. And also they add, they want people to declare how often one testifies and how much compensation one is received for that testimony. A plaintiff's or defense expert will ask that during the deposition to the expert who they've retained, because, you know, obviously if somebody is semi-retired or, you know, 90% of their income is from expert testimony, perhaps they're not really practicing urology and they might not actually be so-called in the trenches and know exactly what is sort of going on. And so an expert should not unduly profit from his or her consultation. So some people have looked at this. There's a group of authors back in 2014 who wanted to look at who actually is testifying as expert urology witnesses. They reviewed a legal database. The caveat is, of course, that you're only getting a very small numerator for what are urology cases, because lots of people can threaten or can be threatened to sue. A lot of plaintiffs can initiate litigation or at least retain it.
Hold on one second. We're just, I think Dr. Nieder had a connection issue where we're just going to reboot his PowerPoint.
I see.
All right, sorry about that, guys. So sorry we got cut off. So back to where we were. That's annoying. So there's another article. This actually came out of Long Island, where they looked at malpractice in endourology over a 5-year period. And again, a very small number of cases they looked at. They were looking at in endourology, specifically retained stents, also cases of ureteral avulsion. The teaching point was you need to document follow-ups if patients, don't come back and have their stents removed, you really need, the onus is on you to make sure that they've been warned. Obviously, you need to review images preoperatively and don't avulse the ureter. That's hard to defend. Prosthetics is obviously a big area for litigation in urology. These authors looked at almost a 15-year period. The interesting thing here, when they looked at their cases, and this goes sort of across the board, most cases are won by the defendant. So even if a urologist is sued, usually about 60 to 70% of the time, you get a defense finding. What these authors found was that 50% of the litigation related to surgical error, improper sizing, bladder injury. But if you look at what they put on for damages, complete impotence and loss of length, this really means that these patients weren't counseled appropriately. And so their conclusion is you really need good informed consent. You need to manage complications quickly and appropriately. And you need for probably advanced surgical training. High volume implanters had better outcomes, is what they found. Robotics, obviously, as everyone can imagine, is a big area for litigation. There's lots of 1-800-BAD-ROBOT ads on TV, or there used to be at least. This is an article looking at just intuitive cases. They found most cases were GYN followed by urology. But if you look at the cases for urology, 40% were related to ED and incontinence. So again, this means that patients weren't being really counseled appropriately, or they just didn't understand the risks. So their conclusion is you really need to improve the consenting, education. You need to be judicious with advertising. If you advertise that you're the best robotic surgeon in the galaxy, and then a patient has a less than galactic outcome, obviously you're going to have unhappy patients, and that's going to come back to bite you perhaps. And they also noted that with more robotic cases, the litigation numbers have decreased, and they thought that's likely a surrogate for improved robotic skills. And just lastly, vasectomy. As you can imagine, this is also an area where people can run into trouble. Again, though, for the cases that went to court, 60%, 65% were won by the defendant. And again, negligence and informed consent, negligence in postoperative care, negligence in surgical performance. Here, 20% of the problems related to pregnancy and wrongful birth, which means in conclusion that, you need, the AUA guidelines are clear. Patients should follow up after a vasectomy until they have a negative semen analysis. And if you're not counseling your patients appropriately, obviously that's an area where you could have some problems, and you should do the vasectomy correctly, right? So if you don't want your post-vasectomy patients to impregnate somebody, if you do it right, that's less likely to happen. And then, the people who complain of sexual dysfunction afterwards, why does that happen? I don't know, but urologist really needs to document sexual function for every patient. And, I sort of push our residents on this too. Even if somebody comes in with stones or anything else, you really want to document what the patient's baseline erectile function is, because somewhere down the road, someone's going to complain that maybe their erections are less than perfect, and they're going to, blame it on your ureteroscopy you did 3 years ago. And if you don't have good documentation that you're morbidly obese diabetic with CHF, didn't have bad erections to start with, why do you want to take that hit? And so lastly, another review article. The interesting thing is urologists will have 2.1 claims per career. So it's not insignificant. Most urologists are going to get sued twice on average. And the average length of time between the incident and the closure of case is 5 years. So these problems don't go away quickly. So what do these authors find? That complaints are correlated with malpractice suits. So when patients complain, those are doctors who are more likely to get sued down the road. It looks likely related to unfavorable interpersonal skills. So what they thought was doctors are less likely to face malpractice if they apologize early, provide a clear explanation, maintain open lines of communication, and obviously don't lie to patients, right? You need to make them understand exactly what's happening and how you're working to fix the problem. So switching gears a little, I'm going to go through a couple cases in areas where people, I've seen at least, have gotten burned or have had problems. So you got to communicate abnormal results. And I reiterate this all the time. You as the urologist, you're responsible for every single test you order, whether it's an abnormal finding is urologic or not. If you order a chest CT and they see a nodule in the lung and you ignore it, you've got potentially some liability there down the road, especially if somebody develops widespread metastatic disease. And you have to really document that you've discussed results with a patient. You should send every result to a PCP. I personally find it dangerous when patients don't have a PCP, because then I'm sitting on the hot potato and I don't want to do that. I want I like to be able to pick up the phone and document that I spoke to the patient's primary care doctor and let them know that this patient has, a cecal mass and it needs to be dealt with immediately. So, and when you communicate, again, ideally with the referring physician, and you got to document it. You document you spoke to the patient and family members. And if you have their names, put it in your note, add their phone numbers, right? If you document that you spoke to Mr. Smith's daughter and you put her number down, that's sort of bulletproof, right? You've obviously done that. You're not making up that information. If that patient subsequently, tries to, initiate a litigation and they send that to a plaintiff's attorney is like, we've nothing to document, right? This doctor obviously has good documentation. So here's a case of failure to communicate results. 52-year-old man, he was incarcerated, family history of prostate cancer. He's referred by the GU prison doctor, the PCP, for an elevated PSA. He ultimately gets a biopsy. He's got intermediate risk prostate cancer. The urologist signs the report. He writes his name, he signs it, he writes the date. And then what happens? Patient never comes back to follow up. Patient apparently refused to get on the bus to go to the GU clinic from one prison to another, never gets scheduled for another follow-up with GU for whatever reason. 7 years later, the patient presents with bone mets. And the prison, doctor writes, they put in a deposition, we never received any path report or documentation. They didn't even know the patient underwent a biopsy. It was done in the doctor's office. The urologist claimed the patient never came back to see me, but he never documented any phone calls. The prison has no record of phone calls, and there's no documentation that he attempted to personally call the prison doctor. All he did was sign off on the path report that showed prostate cancer. This case settled for the plaintiff pretty easily. And I think the teaching point's pretty obvious. The malpractice could have easily been prevented by picking up the phone. All the doctor needed to do was spend 30 seconds calling the prison doctor and letting him know that this patient has to be dealt with. And he would have been off the hook. So another area that we see problems in is laziness, obviously. You can't sit on emergencies. It's really impossible to justify laziness. And as I tell my residents when they complain about, sometimes having to work late or work early, we don't have a 9-to-5 job. And when you're on call, you're responsible regardless of the time, right? We signed up for this job. No one told you have to be a urologist and hold a pager for a week at a time as an attending or a night at a time as a resident. So 2 interesting cases that are similar but have different outcomes. Healthy 48-year-old gentleman walks into an ER 2 a.m. He's obviously uroseptic. He's got a CT scan with a proximal left stone and hydro and perinephric stranding. Most urologists, I think, if you asked a PGY1, would say, we know what to do. So the urologist is called immediately after the CT, admit him to medicine, stabilize him. I will see him first thing in the morning. Tends not to be ideal. He eventually gets around to writing a note at 11 in the morning, 8 millimeter left proximal stone. He's concerned about the white count, hypokalemia. We need to rule out other causes, needs medical workup secondary to very abnormal labs. I will place a stent tomorrow once stabilized. The patient has a prolonged ICU stay, eventually leaves the hospital with bilateral knee amputations. Teaching point, it's really hard to defend. It's difficult to justify delay, difficult to justify not performing emergency cyst or stent or, a nephrostomy. So similar case, 48-year-old guy presents to an ER, same thing, uroseptic. He's got a slightly bigger stone, hydro and stranding. Urology called, sees the patient within 2 hours. I will proceed with immediate cystostenting, he documents. Patient and family aware of risks of continued sepsis despite immediate intervention. Patient and family aware of increased risk secondary to baseline diabetes, obesity, coronary artery disease, and chronic renal insufficiency. This guy stented immediately. He's a prolonged hospitalization. He ultimately expires from overwhelming sepsis. The urologist gets sued. And I think the teaching point is this is very defendable, and this is going to settle for the urologist because the urologist provided totally appropriate care in a timely fashion, and no one would argue otherwise. Obviously, the bad outcome is not related to any deviation in standard urologic care. What about failure to calling for help? and I tell people and tell the residents, we're experts in urology. That's what we're boarded in. That's what we're studying. Not really anything else. You don't have to solve every problem. You just have to identify it and call the appropriate people. So you can phone a friend. You can call a doctor. People ask me, what do you want to do? I'm like, I don't know, call a doctor, somebody who understands what that EKG looks like, because I don't. So 63-year-old woman with coronary artery disease undergoes a TURBT for big lesion. She's admitted post-TURBT to manage her bleeding. The nurse writes this note at 1 a.m. This is more or less verbatim. Patient complaining of left shoulder pain. The family is concerned she could be having a heart attack. The doctor's notified. She ordered an EKG, which says abnormal. This is all in the nursing note. Doctor orders ditropan for bladder spasm, says she will see her in the morning. Seen by cardiology in the morning, taken emergently to cath lab, complete occlusion of the RCA. She gets stented. Post-op day 7, the patient's walking out of the hospital. She arrests and dies. Teaching point, really difficult to defend. Could have probably prevented with a 30-second phone call to medicine or cardiology. Might not have changed the outcome. The patient could have still expired, whether she got stented, 4 hours or 5 hours early or not. But the optics are bad, and this is a difficult case to defend. You need to know your limitations as a doctor or a urologist. You don't have to do every surgery. You don't have to operate on every patient. You can recommend a second opinion. We probably all don't do this enough. You have a complicated case, ma'am. You need to see an expert. I love telling that to patients who are difficult. You can ask someone to help you do a case. This was actually an actual patient I had personally. This was back in May of 2020 when we were, again, knee deep in COVID. I had a patient with a bladder recurrence after an FRU. He needed a TURBT. The son calls me, or while we're on the telemed call with the patient, the son's on it. How can you guarantee my dad will not COVID? He asks me. I'm like, I can't. He's like, walk me through the exact mechanism of what happens when he comes to the hospital until he leaves. Will every single person who interacts with him have been tested for COVID? I'm very worried my dad will get COVID and die from your hospital. I know hospitals are hurting financially and need to start making money and are probably operating earlier than they should. I mean, I couldn't tolerate this. They terminated. I told the patient, I'm sorry, I can't operate on you. It's not an emergency. You need to get this done, but you need to go somewhere else. It just made me so uncomfortable that these people were not going to be happy. And if his dad did get COVID, I don't want to, again, be holding that hot potato. So let's talk about surgical disasters a little. So whole nother bucket of where we see malpractice. So 48-year-old healthy woman undergoes a right hyonephrectomy for a 10-centimeter upper pole mass. So already somebody might say, that's a pretty big tumor to be doing laparoscopically. Op report, they document. Visualization, very difficult. Hard to mobilize kidneys secondary to very large tumor, I imagine. There was a lot of bleeding at the hilum, but we controlled it. EBL 700. Seems like a lot. Then they write tolerated procedure well. Post-op day number 1, LFTs are elevated. Patient becomes unstable, requires pressors. They get a CT scan, edematous irregular liver. General surgery rushes the patient to the OR. On post-op day 3, there's a staple line across the portal system. Patient expires. Teaching point, hard to defend, right? I mean, obviously the surgical planning wasn't ideal, big tumor. Stapling the portal system is not a known complication. A defense attorney tried to get me to say that this can happen. I can understand how this happens. I said, I can't really understand how this happens. I mean, you have to be really lost to do this. Obviously the urologist was, and he could have opened, he could have called for his partner, he could have called for a general vascular surgeon, anybody. The bottom line is he didn't even recognize the mistake. So that was a problematic case. This whole other area where I talk about broadsided by other doctors. So you can't control everything that you do. You have to try and work with good people, but just because something's done one way doesn't mean you always have to do it that way. So this is a case of 2 patients who undergo prostate biopsy same day at a urologist's office. This is probably not that uncommon. Patient 1 is high volume Gleason 7, gets a robotic prostatectomy. No cancer. Patient 2 is a negative biopsy, eventually undergoes a prostatectomy when somebody figured out the jars got switched. Both the urologist and the pathologist are getting sued. Someone mixed up the jars. Both pathologists and urologists claim they didn't do it. What's the teaching point? You always check the jars, the name and the date of birth, because it's usually your MA or your LPN who's, they might be pre-labeling all the jars in the morning for all the for all the patients. So you personally, and that's what I do, before I put anything or have the nurse put anything in a jar, I check all the jars, name, date of birth. And I don't send the biopsy specimens together. So even if I have 2 or 3 biopsies in an afternoon session, I have one of my nurses bring it down to pathology. So they get accessioned separately. Then she'll walk down an hour later with the next group of formalin jars. And then again after that. So intraoperative consults also can be very dangerous. When you're called to do an intraoperative consult, you are now responsible for that patient. So there are ways to mitigate the problem. You can convert to open. You can make a bigger incision if it's already open. You can reposition the patient. You can use fluoro. You can get an abdominal x-ray prior to extubation. You can talk to the family, and you really need to follow these patients closely while they're in the hospital. This actual case that happened to me, this is years ago when I first started practice. I get called to the L&D suite where they were doing some GYN case, and I walk in and it looked like a slaughterhouse. I'd never seen so much blood in canisters. Patients just bleeding out from pelvic bleeding through a small fan and steel incision. So I get in there and I immediately packed. I said, you guys don't need a urologist. The bladder was wide open. I said, you don't really need a urologist. You need a vascular surgeon. We need to get cell saver up here. Vascular surgeon comes in, makes a big laparotomy, ligates all the pelvic vessels. Eventually we get the bladder repaired. The GYN documented the case was progressing appropriately until urology attempted to repair bladder and induced massive bleeding. I almost had a stroke when I read that. But again, I was following the patient. And so we complained to the CMO and the CEO of the hospital. We made him redo the op report, and he was actually forced to write a letter to the hospital CEO thanking us for saving a patient's life. So you don't want to get blamed for something that you don't do. Another intraoperative consult. This was a case where a urologist is called to repair a urethral injury during an APR for advanced colorectal cancer. The urologist attempted to repair, put a couple stitches in the urethra, and he writes, plan to keep the Foley in for 3 weeks. The patient's about to walk out the door on post-op day 5, and the nurse takes out the Foley, and they can't get it back in. So they call the urologist. He has to take the patient to the OR. He tries to do it cystoscopically. Now he can't do it. Patient needs an SP tube and eventually gets a urethroplasty down the road. They're suing the urologist for a bad repair, repair of the urethra at the time of the APR, not suing the colorectal surgeon. And so what's the teaching point? The urologist really should have documented very aggressively the injury and what he had to fix. You know, instead of writing, oh, a small little laceration, maybe to make everybody feel good, and you put a couple of, monocrals in, he really should have documented that there's probably aggressive cancer growing into the urethra, or it was a radiated field, and this repair is tenuous. And the other thing I learned after doing this is you should put a do not remove sign on Foleys. And, I always have my residents take a little piece of tape and we write do not touch and do not remove on it, especially for something that you really don't want to come out. That's easy to do. We talked initially that I was going to tell you about bad documentation and why this is problematic and EMRs are dangerous. And I really think so, because for the most part, people just click boxes, but you really only want to document pertinent positive and negative findings. I go crazy whenever I see people documenting normocephalic atraumatic heads and, patients with kidney stones. It's completely nonsensical. Or people documenting every day that somebody's tympanic membranes are intact. And again, obviously you don't want to copy and paste subjective parts of notes. So this was actually a deposition I had looked at. It's pretty similar to what was actually done. So somebody wrote, "Doctor, you examined your post-op patient every day." And he responded, "Yes. Doctor, do you believe his abdomen was always benign despite the fact that he was becoming increasingly septic and later found to have a perforated colon after robotic surgery?" And the doctor wrote, "Yes, I wrote abdomen non-tender, non-distended." And so then the attorney kept going. "So doctor, do you always carry an otoscope and ophthalmoscope on rounds every day and examine your patient's eyes and ears thoroughly?" I don't really do that. "Do you occasionally do these exams? If we ask nurses at your hospital, will they say you do these?" "Not really." "Doctor, you documented on every post-op day that your patient had EOMI and his tympanic membranes were intact. Was this actually accurate?" "Maybe not," I guess the doctor responded at the deposition. So I just want to be clear for the record, you did or did not examine this patient's eyes and ears. I guess I didn't. the pain just keeps going. So doctor, how do we know what you did or do not do when evaluating your patient if, as you just admitted, some parts of your medical notes are false? That's a hard question to answer. And so doctor, did you purposely lie and document objective findings that were not true to increase your payments for seeing this patient every day while he was getting sicker and sicker and ultimately died? And so again, this is the point where you want to go out the window. If you're sitting there during a deposition, this is not going to make you happy. So again, switching gears a little, you can't hide mistakes. So if you make an error, you need to call for help. You need to attempt to mitigate the problem and treat appropriately. You need to be honest with the patient. You need to obviously be honest with documentation, and you never ever go back and change notes. The computers really do record keystrokes, and so somebody could figure out if you're indenting notes in the past. And you got to call risk management. So in conclusion, you got to communicate with patients and other doctors. You don't want to be lazy. You really need to know your limitations. You need to document everything appropriately. You don't need to take care of every patient. You can offer second opinions. We probably don't, as a specialty or really as medical professionals, we probably don't fire enough patients. I mean, you got to assume a decent number of people who walk through your door every day are just going to be happy and could be a little nuts. And, if you don't feel like you're connecting very well with them, you don't necessarily have to operate on them. You could send them out, because again, once you break it, you buy it. Then it becomes your problem that you have to deal with an unhappy patient. Obviously, you want to try and mitigate potential problems, and you got to manage intraoperative consults appropriately, both intraoperatively and then postoperatively. And that's it. Thank you very much. My email and my cell phone is there. If people have questions, feel free to reach out another time. You can email me or text me. Hopefully that was helpful. Thank you.
Yeah, that was great. Yeah, the personal vignettes are super helpful. I have a question. Do you have any specific recommendations now that patients can access their own charts and medical records and see exactly what you digest the encounter virtually and access their notes? Any special suggestions there?
It is somewhat problematic. And now at least, patients can see their records in real time. At least they can in Florida. I don't know if it's a national thing. But, so sometimes patients are calling the office hysterically with their biopsy results or their CAT scan results before I even, get to look at it at the end of the day. And so, they're stat calling the office. I need to speak to the doctor immediately. It says I have a tumor. And it does become problematic. I think what you put in your documentation, obviously, just has to be very truthful. I've had a lot of patients who, not a lot, but sometimes patients will call and complain saying, I don't have erectile dysfunction, take that out of my note. And I'm like, sir, you sat here and told me that you need Viagra and we wrote your prescription for Viagra. So I don't know what you're talking about. That's nonsense. So I think you just have to be very judicious with what you document. You should obviously be honest. That's it. I mean, but yeah, I mean, it's you get what you get, though. I tell people, right? If you complain of something, I'm going to document it.
It's often like a challenge of time. Like, how do you balance, writing this complete note, documenting all these things and getting through the encounter and your day in a timely basis? It's, I think, the constant battle that we face in the office setting. Do you have any tips regarding that?
Well, I think less documentation is better. Not necessarily less, but more direct and appropriate documentation. So again, I don't, when I see patients in follow-up, I do a very brief review of systems. I don't click every box. I want to know that they're not short of breath and having chest pain if I'm going to operate on somebody. I'm not necessarily asking them, if they've had a rash or, they're feeling anxious and the same thing with a physical exam, right? And so you need to really be judicious what you're asking people, what you're documenting. I don't know. I use some templates, but again, you got to tailor the templates. The templates become dangerous too. I see people who paste in their notes, like 2 pages worth of a template on prostate cancer and what the AUA says and what all these articles say. And I tend not to do it. I just sort of hit the highlights, risks and benefits, and, the 4 or 5 bullet points of what could potentially happen during surgery. And I think that's really all you can do.
Any specific tips for pediatric urologists? You touched on a lot regarding adult urology. I know you don't practice pediatrics, but based on your view of different depositions and cases over the years, any particular points to share?
Yeah. Well, so again, I actually haven't, people have asked me to look at pediatric cases and I always decline. I said, yeah, I'm not an AI. What do I know about this? I can refer you to somebody who might be able to help. I guess pediatrics, the challenge is obviously you have to deal with the parents too. So you got to make sure the parents really understand exactly what's going on and documenting it very carefully, right? And again, sometimes if I just get a sense that people don't understand completely what I'm telling them for surgery, I make them come back the next week. I say, you know what, I want you to think about it. Come back next week. There's very few things that I see in the office that are really emergencies. If you have an emergency, a stone, you're exsanguinating and you're in clot retention, I'm just going to send you to the ER and then we can deal with it. But, if you have a 5 or 6 centimeter renal mass, or even if you've got, high risk prostate cancer, if you don't understand, if I don't get a sense that you understand exactly what I'm talking about, I tell them, come back next week. Come back next week, bring your family member, think about it. This surgery is not an emergency by any means. And we can talk about it a little more, especially for elective surgery, like TURPs or green lights, patients more or less have to beg me to do a TURP or a green light on them, right? Or you have to be in retention, right? Because why do you want to do an elective surgery on somebody who isn't really bought into it? I just find that's problematic. Anything else?
Doesn't look like anybody has any additional questions that they've posed in the chat. So if nobody else has any questions, I think that might be it.
All right. Thank you very much.
There's the link for this survey in the chat, and it's also going to be posted to our Twitter. Thank you so much.